time crunch for today, so we're going to move on.com with Kelson. No better substitute, right? This is the best substitute, man. So we're going to continue with our small talks. Very important topic, especially for me in like 3 months. So yes, we're going to get started with the small talks. Thanks, guys.
Hopefully it's not too depressing. So this is, I'm Kyle. Everybody should know me at this point. Everyone knows where this is, right? Across the street. I'm pretty sure if somebody like had an MI on the doorsteps of this, they'd be like part of Emtala, right? You'd have to go put on a stretcher and bring them. So let's talk about this. We're going to talk about the prevalence of litigation in the emergency room. We're going to talk about how litigation affects us as medical professionals, how it changes our behavior. And then we're going to talk about behavior that predisposes to lawsuits that we might be able to change that would kind of protect you from being sued in the future. So let's talk about the numbers. About 3/4 of all emergency providers will be sued at some point in their career. That's my fun. So that comes out to, if you assume that a typical EP has a 40-year career, it comes out to about 51 months spent in a lawsuit during the course of that 40-year career, just based on the typical length that is spent in litigation. That comes out to about 11% of your career is spent being actively sued or being involved in a lawsuit. It's expensive, right? If there's no indemnity awarded, it comes out to about $14,000 being an expense. If there is an indemnity awarded, it comes out to about $220,000. I don't know if that, I think malpractice insurance covers some of that, but it is still an expense that you have to think about. So it changes our behavior, right? How often do you guys, does somebody like say to you, well, this test might not be warranted, but we have to, if it goes to suit, we have to order whatever test, right? You guys feel like it happens? Like, I feel like it almost happens on a daily basis. Yeah. So it's totally pervasive. There was a national survey that said 9 out of 10 doctors openly admitted to ordering unnecessary medical tests just to protect themselves from litigation. So that's a lot. So what ends up happening is we end up ordering a lot of tests, unnecessary tests on patients that don't necessarily need them, like this mummy up here getting a CAT scan. It comes out to about 2.5% of all the healthcare dollars that we spend in the United States. That's a lot of money, right? That's about $55.5 billion. Expensive. So it affects us psychologically as well. As you might imagine, being sued will have a detrimental effect on your mental health. People have described, there's been a psychologist that describes medical malpractice stress syndrome. So that's when you're involved in a lawsuit and you experience symptoms similar to PTSD. So that's hypervigilance, avoidant behavior, the things that might have led to you getting sued in the past, like seeing patients. So this is a big deal, right? Given physician wellness, its current state. So we know it's common, and we know it's expensive, and it changes our behavior. So how can we potentially avoid this in the future? Are there things that we can do to change the likelihood that you will be involved in a lawsuit in the future? So there's only been one paper on this, looking at specifically at the emergency department. It came out recently. It was like a couple months ago in, I think, Annals. It's a retrospective cross-sectional analysis of 87 EDs in 15 states over 4.5 years. So what that comes out to is about 10 million patients over about 1,000 providers. So they looked at these providers and these visits over the 4.5 years, and they analyzed data related to the years that the provider had been in practice. And that's, they controlled for bias by looking at the years that the provider had been in practice at the start of the study. So that's at the start of the 4.5 years, how long had the provider been practicing, right? So that's important, so it controls for bias. They looked at whether the provider was board certified in emergency medicine or if they were certified in something else and been either grandfathered in or they were just able to work in that particular ED. They looked at whether the provider worked primarily at night or primarily at day. They looked at RVUs generated. The authors of the paper thought that this was a good surrogate for both acuity and volume, which is what they were trying to analyze. They looked at median admission rate for the provider and whether that predisposed to lawsuits or not. They looked at patient volume, just how many patients an hour on average the provider had seen. They looked at whether the provider worked in more than one emergency room, and their thinking on analyzing that was a surrogate for how well the provider knew the system they were working in. Thinking being, if you work in more emergency rooms, you're less likely to be as familiar with just the one in which you're employed. And then lastly, they looked at patient satisfaction scores. And the outcome was being named in the lawsuit over the study period. So over the 4.5 years that they looked at whether the provider was in the suit or not. Does anyone have any ideas as to which one of these might have been significant? What was it? Press gaining, okay. Anyone else? RVUs, okay. Volume. Volume, nights.
If I had an RVU as
It's a good question. It's a billing unit. That
Monopoly money.
It's a kind of a combination of how acute and how specific your documentation is, and takes into account procedures, all that kind of stuff. So, anyone else want to expand on that?
and then you get like a certain percentage of income like, based on how many RVUs you generate, which if you work for a private hospital.
So the RVU is like productivity from a billing standpoint.
Yeah.
So the authors
How
thought
much
it was a
billing you're
good
able to
composite
generate for the
for
hospital, which is why hospitals will reimburse you for RVUs.
yeah.
But the RVU is how much you're able to bill. It doesn't necessarily correlate with how many patients you see and what you do. If you upbill stuff, do a lot of procedures, and you get more RVUs. So it's kind of a correlate.
It correlates with acuity and volume, sort of. That's what they were thinking. So what it turns out is the only two things that matter are volume, right? Makes sense. So for every 1,000 patients you see, you have an odds ratio of 1.09 higher likelihood of being sued, being named in a lawsuit. So that makes sense, right? The more patients you see, the more likely you are to be involved in a lawsuit. The other thing was years of experience, and it doesn't work in quite the way that you think it's going to work. It turns out you're actually more likely to be sued later on in your career than earlier, at least according to this study. Patients that have been named, or doctors that have been named in a lawsuit were on average in practice for 15.7 years at the beginning of the study versus 11.8 for those that were not named in a lawsuit. Yeah.
Does the volume, does that kind of even out if you, like, is it like per 1,000 patients, is it the same, do you have the same likelihood of getting sued per 1,000 patients, regardless of the time over which you see 1,000 patients?
I think so. I don't know if they specifically analyzed it for that. But yes. Okay.
That's the number of visits per year at the hospital, right?
So yeah, I mean, so they look at the amount of visits. For every 1,000 patients you see, you're about 9% more likely to be involved in a lawsuit. Does that make sense?
Per doctor.
For the doctor, right? For the doctor.
So it's inevitable, is what the data says.
Okay.
Like, it's a
Right.
You
Right.
see more people, you'll eventually get sued. It's kind of,
Yeah. And then, so the later on in your career, so for every year you practice, you're 4% more likely that year to be sued than the previous year. All right. So just in terms of the volume, just so you kind of like are aware of what the study was dealing with, it was that many visits. It was almost 10 million. There were still only 98 claims, right? So if you do the math and say, 30 patients a shift, 150 shifts a year, that's 3 shifts a week. This comes out to being sued about once every 20 years of practice. That's pretty conservative. It's in line with previous estimates that I mentioned earlier. And there are some things that this study doesn't address either, right? It did not control for patient characteristics, so this was intentional. They didn't want to analyze insurance status of patients, chief complaints, or patient demographics, ethnic, national backgrounds. They didn't want it to lead to discrimination. It also doesn't take into account the experience or demographics of local malpractice lawyers in your environment. The last thing is how many diagnostic tests work, right? So that's kind of what we were talking about earlier about it changing our behavior. So this study doesn't address that. There are some caveats. A lot of people mentioned Press Ganey scores at the beginning is probably affecting your likelihood of getting sued or not. This study said no. There are previous studies, especially in other fields, that said it does affect your likelihood to be sued. The discrepancy is explained by the authors as being emergency physicians just have such little time with each patient that you can't be nice enough to prevent it or be mean enough that they just really want to take you to court. That's the way they explain it. Whether that's true or not, I don't know. There's other data from the ED that says that patient satisfaction scores aren't associated with risk management events unless there's a complaint that goes to administration. So to me, that says if you tick off a patient enough that they say something to somebody, you're probably more likely to go to court for that. So I think the jury's still out on this one. Right? It's not definitive data. So diagnostic studies, right? CAT scans. This wasn't looked at. In this study, there have been a couple other studies that they only look at successful suits. And what it shows is that the most common cause of a suit that's successful is a failure for a diagnostic test. So that means that it might not protect you from actually going to court, but it might actually protect you once you've been to court, unfortunately. From the suit actually going to award an indemnity. So that's it. These are the take home. Sorry for the depressing content. I'd like to be sued at some point. It changes our behavior, unfortunately, leading to more diagnostic tests and heavy expense. Sorry, Dr. Sinner, more patients, more lawsuits. You're more likely to get sued at the end of your career. But I think that the really important thing here is that if you are sued, if and when you are sued, it doesn't mean you're a bad doctor, right? It doesn't necessarily mean that there's something that you're doing that led to this lawsuit aside from just seeing patients, which is our job, right? Nobody's just going to stop seeing patients because they're going to get sued. And I guess the last thing that I'd like to mention is that admissions didn't make a difference, right? So the quote-unquote defense of admission might not actually protect you from being named in the suit, right? Yeah.
Is this emergency doctors being sued individually, or like they're suing based on the whole care they got?
So it's being named in a suit. That's a good question. So my impression, and I'm not a lawyer, right? My impression is that if somebody takes a case to court, they kind of name anybody at any point in their care in the lawsuit. So it could be something totally unrelated to your emergency care management.
I'm not a lawyer either, but the ones that are reported and kind of, I think, filed are the ones that you kept on the suit. So the one where everyone's named and then you get dropped later, I don't think that's probably what you're getting in your statistics. So just to be aware, I'm not sure.
It depends where your data comes from. If it's self-reporting, then maybe. If it's what's listed in the listed websites, then yeah, probably.
I want to just echo Kyle's second to last point. I think that's really important because when you do get sued, it's a big deal to you. It's emotional, and you can affect your practice and your life. But it may help to remember that pretty much everyone's going to get sued, so that if you practice it for a certain amount of time, it doesn't mean you're a bad doctor, it's just unfortunately part of the course.
Yeah, thinking back to August, when I got sued, it really made me feel like I was a bad doc for many months. I was like, am I really doing the right thing? I really questioned my ability to take care of patients. It made me feel terrible.
Talk to your mentors, talk to your colleagues, it can be very helpful.
And just one nice thing about working here is that often, both in Canada, especially at UHD, that when they go to make the lawsuit against you here, a lot of times they'll go for what's called the deep pockets. So they'll make some kind of deal that they don't name necessarily you, but they'll name the city or the state. And sometimes even like here at UHB, I know from one case that I wasn't named even though they sued the hospital and the state because they were going after deep pockets. Plus the lawyers on both sides of the issue will try to get your names dropped, and often they will take it on as it, unless the family is so angry they're not going to allow their lawyers to negotiate, but usually they will. So that's a nice thing about being here.
Brian, yeah. Two.
That's in contrary to some states where if you get sued and the suit is above the maximum that your insurance will pay out, then you become liable for the difference. Like all the money above the maximum that you're covered for. So in New York, you're covered, let's say you're covered for $1 million, and they sue you for $22 million. And they win. You're on your line.
It's rare to go above the $3 million coverage.
There are states, just to be aware, there are states in which you are personally liable if you're sued above the amount of your maximum.
Nobody ever paid that, so it's like.
It's very rare to like go after that figure that's above the amount that they cover.
Good? Good. Thanks.
All right, thank you, Dr. Kelson.